Thanks very much, Dave. So I'm Colin Tan. I'm one of the other interventional radiologists with Sydney IR Group. And I'm going to be talking on spinal injection and vertebroplasties. So we know that back pain is a very common problem and a significant cost to the community, as well as to work and to productivity. So there's a set of guidelines that has been produced by the Australian Council for Innovation. It's been published and it provides useful information on the management of back pain. This presentation, however, is really more to give you an insight about the role that interventional radiologists can play in helping your patients with back pain and what your patients can expect during the procedure. So there's a number of causes of back pain, a lot of which are attributed to musculoskeletal and degenerative type diseases. As IRs, we're often able to help patients who have these facet joint disease or radicular or sciatic type symptoms, often due to nerve impingement and to disc disease. So it's important to rule out some of the rarer causes, and that's to exclude those more risky and dangerous sinister causes such as trauma, infection, or malignancy. In regards to radicular pain, this is a type of pain and the symptoms such as numbness and tingling that occurs along the nerve root distribution. It's commonly caused by inflammation, either from disc disease or degeneration from facet disease. It can be in the neck, in the setting of cervical vertebroplasty, where the pain often radiates to the shoulder, as well as to the arm, and down into the hands and fingers. In regards to lumbar vertebroplasty, this is often described as sharp and electric-like pain and numbness. It's caused by nerve root irritation from mechanical compression or inflammation from the adjacent disc or the adjacent facet. L3-4 is often referred to the anterior thigh and to the groin. L4-5 more so into the knee, on the side of the leg and the foot, and L5-S1 more into the foot, the back of the thigh, and sometimes to the buttock region. So all these are really quite common, and often a spinal injection is recommended. So here's a lumbar nerve root image under CT guidance, and you can appreciate how good the resolution is as the needle is placed within millimeters of the nerve root. So for those of you who aren't familiar with reading the CTs, this is a patient prone position. Spinal canal in here, where the thecal sac is, vertebral body, and you can appreciate on the left side of this image, that's a needle trajectory coming straight down. The nerve root is actually coming out this little channel here. So that's where it will get impinged from the disc, which is sitting on top of that intervertebral disc base, as well as the facets. So you can appreciate that needle tip is getting placed within millimeters of the nerve root, and that's where we'll be targeting to inject. So facet disease can present with neck pain, and it's often worse with neck movement. It can also present and often is misdiagnosed as migraines or headaches. And the location of the facet disease can often correlate with the location of the pain. Lumbar facet disease. This is often described as low back pain aggravated with some movements such as sitting, sometimes relieved by standing and walking. It's often worse with back extension, and patients often describe symptoms such as a morning ache or a stiff low back, particularly when they get up. Generally, there's no radicular type pain, but it can, on occasions, present as radicular pain. On examination, they can be focally tender, right on the facet. So here's an image of how we target a facet joint injection. You can see, so again, patient prone position. This is L4-5, this is the intervertebral disc base, and you can see the facet, a little bit degenerate, contralateral side, has this big bony hypertrophy, osteophyte. This is the problematic side, where you can see the needle going straight in. Now that facet is probably only 1 or 2 millimeters, and under CT guidance, we can get that needle right into that joint space. So conservative management, that's often the initial treatment and initial recommendations. But often, there's persistent symptoms, and then imaging and a spinal injection is often suggested. So in regards to imaging, these can often help identify a problem. So what do you request? Well, I think that the most diagnostic information often is from cross-sectional imaging. So that's a CT or an MRI. So here's a patient. I should say, I think the bone scans can be useful, but often for a diagnostic dilemma. So this patient here is a young gentleman, probably in his 50s, who had a bone scan showing C2-3 facet arthritis. And so this helped guide us to a C2-3 facet joint injection to help with his pain. So by far, the most common indications or the reasons that we perform a CT-guided spinal injection is for pain. And that can be either acute or chronic and usually caused by inflammation. It's also a useful diagnostic tool. We can help identify the source of pain and therefore confirm the diagnosis. Then there's patients who have side effects from medications or who are averse to taking long-term pain medication. Sometimes we'll do an injection if there's persistent pain after surgery or if the patients are not suitable for surgery. So why use CT? Well, there's a whole number of reasons, but it's much better, it's more accurate, and it's much, much faster. So here's a single slice from a contrast-enhanced CT neck at the C5-6 level. You can see it's got great resolution for most of the anatomical structures in the neck. And if you were to place your needle, you can place it with great accuracy. It's also done in real time, so we generally get it done within a few minutes. The other great advantage is that we can perform a diagnostic CT with contrast. So if we get a challenging case, for example, if you need a C1, C2 facet joint injection, which is a little bit risky from our perspective because of the vertebral artery, we can perform a CT angiogram first whilst the patient is on the table just before they get the injection. I'd be particularly careful about doing injections under sort of X-ray fluoroscopy, especially given the high availability of CT and the significantly improved resolution and the safety margin. So I know exactly where my needle tip is located to the millimeter and its relationship to critical structures. So here's two comparison images of like the spinal injections. One on the left is a CT, and the other on the right is under fluoroscopic X-ray guidance. So the information and the safety profile that you get from knowing exactly where the needle tip is located is critical. And most of us would appreciate this, especially in something like a medical legal setting. So the three types of spinal injections that we perform are facet injections, the nerve root, and the epidurals. Note that we often use the term foraminal or perineurals and nerve blocks a little bit interchangeably. And these are useful for the treatment of sciatica and for vertebroplasty. The epidurals are generally performed at the lumbar levels for canal stenosis and if there's multiple levels that are involved. So lumbar epidurals are indicated for pain associated with disc degeneration, canal stenosis, or nerve root inflammation. So this image here is an epidural. So the needle has tracked down into the right side of this image in the epidural space. And you can appreciate there's a little bit of contrast which has been injected in. And that is the epidural fat, at which point the nerve root will come out here. So there's probably a disc which is herniating into this patient's nerve root. So what do we inject? So this is our cocktail of medication. Basically, we give local anesthetic to the skin, then we give a little bit of contrast, usually, to confirm our needle placement, whether we're at the nerve root or within the joint space. Then usually a mixture of corticosteroid, which can either be particulate or non-particulate, some people call them crystalline or microcrystalline, mixed in with a local anesthetic, which can either be a long-term anesthetic or a short-acting anesthetic. And most of this cocktail is variable depending upon the proceduralist. So this is how the injection generally goes. This is looking from the radiographer's perspective. This is a control room. The radiographer controls the machine from the outside, shielded by lead-lined glass. The patient's inside the gantry. We've just performed the planning CT, and that's our typical sterile prep. So once the planning scan is complete, we enter the room and draw up the medication. And under CT fluoroscopic guidance, in real time, the injection is done in a few minutes with relatively low radiation levels. You can see there's a monitor and a control panel and a lead shield in the room, so the proceduralist has control of the machine. And this is a gentleman who had the C2-3 facet arthritis on the early bone scan. So what we do a planning scan on the left and we do a check and adjust and slowly advance that needle in real time into the joint space, confirm it with contrast, which is this here, after which we will inject the medication. These injections are considered low risk, with most complications related to the steroids injected. There's always the theoretical risk of infection, drug reaction, and bleeding. And there's some extreme rare reports of nerve injury from injections, but these have generally been reported under fluoroscopic guidance, not CT guidance. So in summary, these spinal injections have a high success rate for pain relief and hopefully improving mobility and quality of life. I often suggest to the patients that they continue their physiotherapy about 1 to 2 weeks after the injection, which can improve their muscle strength and core stability. So in regards to future direction, I think that improvements in CT will hopefully see further reductions in radiation dose. There's a little bit of research with injections of other medications such as PRP or prolotherapy, which is like a high glucose concentration, which we've done to incite inflammation. One area which we've started to commence a service for is radio frequency ablation of the nerves, which innervate the facets for the treatment of facet joint pain, mainly the lumbar levels of the stage. So RFA is a thermal ablation technique used to ablate the nerves supplying the facet joints. So what we do for these is we usually do a test injection to ensure that the ablation will be successful. And that's a medium branch block. And if this works, the patient has a second follow-up procedure where the ablation is conducted. So that machine in the middle, that's the ablation machine, and the needles are placed right at the median branch. It's thought to provide pain relief for up to around 18 months, after which time the nerve will regenerate. This is a tip of the ablation probe, which shows that typical ablation zone. We generally use one on the left, which is the cool RF, allowing for a 10 millimeter ablation lesion. So this is image on the left is a CT demonstrating the tip of the probe, and you can see on CT it can be positioned very, very accurately right where we want it to be placed. Just on a quick aside note, it's not only used in spines, but can also be used in large joints such as the hip and the knee. And again, the probe can be placed very, very accurately right next to the genicular nerve to perform a quite precise ablation. So that concludes that spinal part. I'm going to spinal injection part. I'm just going to a quick word on vertebroplasty, which is my second half. What is it, and why am I talking to you about it? Essentially, it's a procedure where we inject bone cement into a fractured vertebrae to stabilize it and provide pain relief. And the reason why I'm talking to you is because it actually disappeared off Medicare probably about a decade or longer, and it's recently been reinstated. They conducted a randomized controlled trial at Liverpool Hospital and St George Hospital, and that was a positive trial, and since then it's been reinstated on Medicare. So usually these fractures are osteoporotic compression fractures, and these patients get persistent, severe back pain, often unresponsive to opioids. And the best candidates for this procedure are generally the patients with acute fractures, no neurological deficits, and generally the older population with osteoporosis. So this is the Medicare descriptor 35401 for vertebroplasty. It's for one or more fractures in one or more vertebrae performed by an interventional radiologist for the treatment of painful osteoporotic thoracolumbar vertebral compression fractures of the thoracolumbar spine, T11, T12, L1, L2. So if I isolated four vertebrae, if A, the pain's severe, and it's got to be 7 out of 10 or more, and B, the symptoms are poorly controlled by opiates, and C, the severe pain, duration 3 weeks or less, so it's actually an acute fracture. And D, there's MRI or SPECT CT, which is essentially bone scan, evidence or imaging evidence of acute vertebral fracture. So as you can see, a really tight criteria to satisfy Medicare. So this is how it's performed. Patients, they're usually admitted as a day patient, or the patients are already admitted. They get conscious sedation and local anesthetic. The needles are placed into the vertebral body via a transpedicular approach, under fluoroscopic guidance. Then the cement is injected into the vertebral body, and the cement hardens over the next few minutes. And the procedure is well tolerated, and patients recover quickly with no large incisions. Patients report pain relief in about 24 to 48 hours. So here's a quick case that was performed probably about 3 or 4 weeks ago. This lady is 87 years old, has an osteoporotic spine, multiple thoracic fractures. She developed acute pain. The mechanism was not quite clear. She had a CT and a bone scan of her spine. And this is imaging. So on the left, you can see she's got a kyphosis, and you can see the bone scan really helps to identify the acute fractures, which are the T12 and the L1 fractures. So this fits into the Medicare criteria as appropriate levels to treat. So we discuss this with the patient. She consents for the procedure. So this is a lateral fluoroscopic image of the 4 needles being placed into the vertebral bodies and the cement beginning to be injected in. So 4 needles, the bones are a little bit loosened because she's osteoporotic, and you can see the cement, which is a little bit more hyperdense, getting injected into T12. So we only have a few minutes to inject cement once we mix it up. So we try to get all the needles into position first. And you can appreciate the dense bone cement filling the osteoporotic fractures. So this is a high-resolution CT image of the bone cement after the procedure is completed. You can see how it's filled up and stabilizes the fractures. And by minimizing the fracture movement, it reduces the pain. So vertebroplasty has a number of benefits. It reduces pain and immobility. It reduces suffering from pain and immobility, and allows patients to have early ambulation and rehab, thereby reducing the need for extended rehab and nursing care, and also potentially reducing the cost of treating osteoporotic fractures in the population. And risks, what are they? Well, these are mainly due to the cement leakage, especially when it's injected in. So the cement acts like a slow liquid, so it can potentially leak into the surrounding tissues. So we minimize this by watching cement under fluoroscopic guidance as it's injected in. There's also this risk of fracturing the vertebrae above or below, largely due to having a sort of a soft vertebrae above and a soft vertebrae below, with a hard cemented vertebrae in between them. So those are the main risks. Generally, the procedure is well tolerated, and most patients get a good, long-lasting result with improved mobility after the procedure. And